Yeah, recording, yes.
Yes, okay. So what I'm going to do today is that I'm not going to stop recording even if we have a little break, so that I won't forget to put it on again.
Okay.
Okay, so what we are going to do today is kind of just try to bind it all together, and
Okay.
the first 4 chapters plus starting on our next venture, basically, which is treatment.
Yeah.
And the treatment planning is pretty tied up with, of course, with the first 4 chapters, which are really supposed to, teach you how to approach a client, that depending again on what kind of environment you're working in, have the proper documents, have the proper knowledge of the kind of treatment that you can offer, and other treatments that are being offered possibly or might be offered. And and to know that the screening process is kind of the initial questionnaire where you kind of just check it out if the person might be, and if they come in positive for that, for addiction, possible addiction, or eating addiction, that we actually go ahead and have them have a deeper interview with then background information, and then assessment questionnaires. And then as a result of the background information and the questionnaire, we will have some substantial to understand what kind of treatment we would recommend for the person. And for me, as I've told you, I work privately, basically, for the most part, and I don't have the possibility of really working with a lot of the people that come into me, and like, for example, now there is a lady that would need to be in an inpatient treatment for the most part. She is in that kind of physical, mental state that she is barely being able to take care of herself. And for these kind of people, you do the best you can with what you have, and you explain to them that they're really going to have to work hard themselves and get extra help and things like that. So you need to be very aware of where your limitations are in the kind of treatment that you can offer. It was wonderful to get Bitten in there yesterday with the kind of with all her wonderful material and incredible work that she does. I love it, and I have been missing so much to have this biochemical repair thing. Somebody that can really work on that with me here in Iceland. I've not really found anyone. And there are so many people that come in that would so benefit from that. So I've tried to learn a little about it so I can support people with some things. But at least 2 people at this point really need this kind of assistance. And I was actually going to ask you, Monica, for the kind of work that you would be doing, if I could maybe recommend a couple of them to talk with you even.
Yeah, that's fine. Because I mean that's what I love doing. That's really my thing too. So yeah, I love that bit.
Yes. So we'll see what kind of, I'm gonna talk with you a little bit in later on about what kind of work that you do, so that I get a better picture of it, Monica. And I had actually asked bitten to find somebody for me that would be able to work further on with these women that I'm talking about. So, but then again, what I also have talked about, and I wanted to mention again, is that each and every one of us have different backgrounds, and so that we basically will always individualize somewhat our treatment. Like, you have certain knowledge, and now you're getting, you know, the learning to deal with addiction counseling, and learning more how to approach that and support that kind of counseling. And that will be an addition to other knowledge and experience that you have. And of course, you have basically learned the addiction counseling part somewhat, and worked with that for years actually. So you are basically working on, you know, what's the difference with the food and eating addiction, and really getting that information more into your knowledge, and adding that slowly but surely into the bank that you have. And maybe so that you can, as you screen people and assess them, you can see better where you can use, where you need to, how you need to work with the people that have this particular disease, for example, so that you can assist them better in getting their recovery from food addiction. So
yes, no, I'm really looking forward to that, because then I can sort of do the food addiction counseling as well as some of the the biochemical and that I normally do.
Yes, and that is really as I said, you know, the two together is just really wonderful. And also people have been a little overwhelmed with all the material that we're bombarding on you. And I just want to say that this is just material that you're going to be having, and you know, that you can reflect to whenever you need more information. You need to go back to getting some answers. You know, you're not going to learn the whole thing by heart in 4 months. It's not going to happen. And but you need to learn by try to learn by doing somewhat. And
that's the main thing. I like learning by doing, because it's the only way to really learn. It's by doing it.
Yes. So that is why I've been, I was, yesterday I was basically suggesting to people that they pair up and do the assignments, and do, or to get a client or a friend or somebody in your surrounding to practice on, or even more than one person, that really start to get things together the way you think you would do things. And you can use any of the material. I don't know if you saw the questionnaire from MFM that is from me in the Dropbox or the WeTransfer. Hello,
can you hear me?
Oh yeah, absolutely.
You disappeared for a few seconds. I don't know what happened.
Oh, okay.
Okay.
I didn't see me disappear. So, but there was a little there was some kind of an echo or something.
Yeah, it was in. I think it's it's the connections, the internet connections, I think.
Yes.
Yeah, I was just going to say to you that well, I have a friend who I've asked today, and she's okay with that. And then I've got someone else here who so I've got two people I can use.
Oh, great! That sounds really good. That's good. That's good.
Yeah.
So now you can kind of gather the material together, and you can use my questionnaire or Bitten's questionnaire, which I think is of course extensive and excellent. it would be asking questions that I wouldn't go so far into, like the health questions, because I don't have really the knowledge. But I always do ask in general what kind of problems people are having, both psychologically and physically. So, but that might be a questionnaire that you'd like to develop for yourself. Did you see the material? This, did you go over the material so you know that what I'm talking about?
Yes, yes,
Okay.
I know what you're talking about.
Yeah.
And I will use all that, and I will sort of have a look and see what I think is that I need to use. But
Yes.
it's really good. I'm not overwhelmed because I'm used to the I know a bit and stuff, and I'm used to the questionnaires and things. So I just want to practice. That's it.
Right.
That's it.
Yes, it's like what I like to do, and I remember when I was studying the hypnotherapy. When I was learning the different kind of techniques, I would just really make up lists, like a skeleton for me. This is what I do first, this, like sentences of little short sentences of reminders, so that I would go through all the process that I was supposed to go through. And then I just I just had that, and then kind of started using it, and then it became like a default for me. So that's one way of doing it, and just let yourself flow with it. And I remember when I was studying to be a counselor, I would have counseling sessions with my clinical supervisor all the time, and just for me, for myself, but also to learn, and from him, and that's also what I've done and did when I was learning hypnotherapy. And the clinical hypnotherapy was to have a lot of hypnotherapy with different good hypnotherapists, and so that you learn the way that they do things. And that's how I kind of felt that I learned the most, basically. And I understood at that time also that I would never be the kind of counselor that he was, that he was going to always be a different kind of counselor from what I was going to be, because we're two different people. We have similar knowledge, but the background is so totally different. He's a male, I'm a female, and I from there I just started supporting myself within being the counselor, and developing and trusting myself and my instinct that comes with sensing the person. But as we are starting to go into now with counseling techniques and such, which is in the next phase, it's pretty much the listening. It's the listening, which is probably the most important, because when you really listen, not just to be able to bombard the person with the next something you want to educate them with, you really get the sense of the person, and that is so important. And I know that I am a very, very, and I'm going to talk about this much more, a codependent person in my background. And I know that the positive part of that is that I've learned to be very sensitive to other people.
Oh yes, I know.
You know the feeling?
I do.
I know, and I'm grateful for that today. Actually, I really am, and not that it was it has been a long road for me to get out of and learning to care for myself and all of that. But it's also been an experience that I can, others can benefit from too. So that you kind of get started with, I recommend the Uncope from Bitten. which is actually the same as the ICD-10, but is developed from Bitten, and we can use all of her material if we just credit her, and then I recommend the background information similar to mine or to hers, the questionnaires, to really get the background from people. I like the way that she of course mostly works through the computer or through phone. So she has people do it and send it, and then she views it and has an interview. I mostly have people one-on-one. So and plus people on the internet, but mostly
Yeah,
one-on-one.
yeah,
Yeah.
I
So
also do one-on-one. So yeah.
yeah. So that's so the MFM questionnaire is. I get most of the information that she asks for in that kind of interview. You know, I draw out it's the same kind of information basically, but I just do it as we talk, and as I'm working with somebody like that, you know, there's a certain flow that of the questionnaires that I've developed and I find good. So I would recommend that you took a look at mine also, just to get the flow of it. It's more simple, and so you might use that as the simple kind of part of it, and then maybe use some of the questionnaires that Bitten has to go deeper into the material. So that's something that I would suggest. And as the interview goes on, it's what I really always try to get the person to start talking, just telling me the story. I ask a direct question, and then I listen and have the person really tell me what it is that they want to tell me. And I try to kind of guide the way with direct question. And then in between, when there is an opportunity, I orient. I kind of get in the information about what it is. Why would we do food addiction treatment? You know, I try to get in information like something about the dopamine receptors, and that it is a physical disease. It's not the character. You know, to really draw a person in and tell her that it is something different from what they think, and they always thought it was their fault, and they needed to be shamed about it. And so kind of try to get them in there in that way. I think is very, very important for a person. I know it was for me when I understood for the first time that it had nothing to do with my character. Of course, it took me a long time to acknowledge it and really sense it in my body that it wasn't. But the understanding of it, that it was, really relieved me of a burden that I had for a very, very long time. So it's a question of the flow also in the interview. And once you get to the family, I usually ask about the family before I go into trauma, because when I hear what kind of a family a person has there been alcoholism in the family, somewhere in the background, or with parents or siblings, or anywhere, or with a partner? I ask specifically about the partner, and then I kind of can. I kind of get a picture, and I'm sure you know what I mean because you worked with Pia Melody's material, and so then once I hear about the and I really let them know that I'm asking about the family, not so that I know everything about all the dirty laundry in their family, but because of the genealogy. So I kind of take that point of view. If there is some kind of eating problems, drinking problems, or different kind of problems, health problems, that may indicate that there is a gene, the genes are in the family for addiction. So once that is established, which is in the most case, not every case can we see addiction in the family at all. And when I get a person that doesn't seem to be coming from an addictive family, usually always there is some kind of trauma in the life of that person. And of course, we know there is trauma underneath it all. And but I loved when Bitten was talking about it yesterday, and she's so clear about that. This disease is not originally because of trauma necessarily. It is a physical disease, and we need to treat it as such. But it's very often triggered, in my opinion, by trauma and disconnect. So it is also there again, kind of a difficult subject to understand, but for a lot of professionals still. Okay, so I think this is pretty clear for you, because you really have that under your belt pretty much. But any of the information here in this chapter, like we have the preparation, the pre-contemplation, all of this, we went over that here last time also, the preparation stages, and then we have the dimensions. Here we're talking about taking the history, and then we're coming into the ASM dimensional criteria to evaluate what kind of treatment to set up for a person. And we have this thing here to kind of, and I think I'm gonna try to set this up like similar something like this that you can maybe Xerox or print out, for your use if you want, not filled in,
Yes,
so
definitely.
Yeah, I was thinking of making one up like that. I need a little bit of help from my printer. I have a printer now. He's helping me with the workbook. We're putting it all together, and I need to be learning to do this printing thing, and it's not really easy, but I'll have him help me with doing an empty one like this too. So, like, what do you think you might be using something like this yourself, or what do you think?
Yeah, I think it would be very good to have. Absolutely.
Yeah.
So
it's the treatment levels, the early intervention, which is basically when you get the people that might have a problem, early stages. And in the material from Acorn, there is the stages, the similar kind of stages of assessment questions. We'll go over them a little later. So those would indicate also and are in accordance basically with these levels. And they tell what kind of treatment will be. And then there is actually an appendix, which I will be actually putting in as one of the appendix to the workbook from Phil, which is the different stages and what kind of treatment recommended for different stages. And that's pretty much similar to what they recommended here, actually. But it's more to the point with food addiction treatment. So level 3, the residential. I wonder when we're gonna have those, huh? Oh my God.
Yeah, well, we don't even have a lot of residentials for you know, alcohol and drug abuse. So how long is it going to be before we have for food?
Mm-hmm.
Well,
Yeah, I know.
who knows?
Yeah, we have Sandra and Mary up in Canada. They're working with a obesity doctor, and Sandra has started with a group working with food addiction. But she was telling us about it yesterday, that there needs to be a doctor sitting in on the session so that they can get it funded. And for some reason, they wanted her to do a food addiction treatment session. And I know Vera Tarman has been helping her with it, and me also a little bit. And the doctor still feels that this is a learned behavior that can be unlearned.
Yep, you know, it's funny because there is a doctor here too, who's actually is a friend of mine, and he also has obesity clinics and gets lots of funding for he's an associate professor at the hospital up here in Brisbane. Yeah. And he doesn't understand, you know, he does not understand the addiction part of it. It's, no, he doesn't. I'm actually going to have a talk to him a little bit later when we've done a little bit more on this and see, you know, because he has a couple of private clinics as well as working in the hospital. Yeah. So, you know, I'm just going to see what he has to say.
Yes. And I think actually just between us and actually between everybody who listens to this also is that I think we need to, I was thinking about it, and Sandra and Mary were just asking me yesterday, so what do you say to a doctor or a person like that? And I have been trying to tell them and point out the scientific evidence for years here, and it almost killed me, you know. My work and really giving, and they would just always, they would listen and say, and then they would discard it. Totally discard.
Oh, I know. That's what I've done this for years and years too.
Yeah.
So I know what you're talking about. Yeah. But
so I think we need, as a school, as a team, to set up some kind of a statement. And that as professionals, that people like other professionals, not to discard scientific evidence and statistic regarding this, treatment for this disease. And we, it might be something that we can do as a kind of a political statement from our school. And I'm actually.
Oh yeah, I'd love that.
I think we need to do that, and that is something that everybody will be able to use and take into their surroundings. And actually, we're working on, me and Olaf, statistic for as the result of my treatment for the past years, and I think we got over 300 something people that we got to from the people we tried to send the info to. We got like 200 something responses. So we had like 70 something percent response to the questionnaire, and we're working through the statistic for that, which is, I think, pretty good. So we'll see we'll have something to tell you about that. But anyway, residential, I'm hoping that there will be, and I think if the money people would understand If
Oh,
we could
yeah.
get the money people in with us,
Mm.
they would
Yes.
see that they would benefit from really doing this kind of work. But I don't know. It might, we may need to wait a long time until.
Well, we
So,
can only do what we can do,
yes,
and hope that, yeah, it's going to eventuate.
yes. But the intensive outpatient and the outpatient is the kind of treatment that is more likely for any of us here to be doing. And I've had kind of a semi-intensive outpatient treatment. So I've had like a weekend, and then like twice a week, and then once a week, kind of weaning people off into 12-step groups and stuff like that. And that is one way, and I'm going to be teaching you that kind of treatment. And the outpatient also the evening, working on evenings and weekly groups, things, individual sessions.
Yeah, that's great, because I mean that's all we can do at the moment when there is no residentials.
Yes, yes.
Mm.
So, and the 5 days when you come here, then I'm kind of basically going to be letting you go through the motions of that kind of, simpler inpatient, semi-outpatient inpatient treatment model that you might be able to experiment more in your environment. And so the early intervention is lectures, talking about it, having people come in for sessions, maybe on a monthly basis with some kind of a direction. So why don't you try to take out the sugar and maybe starches for this month, and add on to eating more vegetables and healthy and blah blah, and as people kind of grow into doing more and more of that, they may come into a more extensive outpatient treatment and
Yeah,
or 12-step
yeah,
programs,
yeah.
Okay, diagnosis versus dimension. So we talked quite a bit about the DSM-5. Can you hold on just a second? I need to close the window. It's cold when it's open. The window is open. So we were talking about the DSM-5 and what Degorski is saying about it, and I probably saw it in Bitten's material. And as a result of that, I decided, of course we have, and this workbook that I'm working from is working from the DSM-4, as we know and as we see there, which was on the right track for addiction professionals. And now addiction professionals feels that the DSM-5, the American Psychology Association, has really backed away from real definition of addiction. And so I think I'm not gonna wanna set up the DSM-5 in this workbook, not at this time. It may change, but I'm going to be using the DSM-4 criteria the way it is there, and adding on to it the ICD-10, which is okay. And I like the approach that they have there. They seem to be on the right track, and obviously we just really, really need to help them stay on course. And I want to put the well, the new ASM, or from 2013 ASM a declaration of addiction being a brain disorder. They have a short version and a long version, and I'm going to put both of them in there actually in the workbook for people to have, or as appendixes probably. So, but those are the ones that diagnose, and doctors are the only ones that can diagnose, I'm told. But we can assess, we can screen, map, and assess.
Yep, that's right.
Yes, and that's what we do. And the diagnosis is fucked up, for sure. You know, and until that they really get in there with their diagnosis for food, you know, we are also politically not strong, because we really need to get like for the ICD-10, the substance abuse, unidentified substance abuse, for example, there might, you know, that it might be food, for example. You need to get that in. So we're in the process here in our workbook as well as in the world. And I know that Phil, for example, and the Food Addiction Institute board members have gone to the DSM and the conferences of the American Psychiatry Association, just to make a point with food addiction. They've written letters after letters about them putting it into the, you know, putting focus on research for the chemical part. And they have actually, in the latest version, they have a sentence that the binge eating disorder shows the same kind of, in many ways, the same kind of, looks like, in many ways, chemical dependency. But I can't remember quite how they say this sentence. Phil will for sure tell us all about that. And I think I got it somewhere in the material too. So slowly but surely we're getting there. And here we're talking more about the ICD, and then here we're having the two scenarios from the A and B. Did you get to see or take a look at these two, Monica?
Yeah, we did. We did in our study group not this week, last week.
Yeah.
Yep.
Okay, so was that something that you could kind of, were you okay with the analysis that came out of their history? Yeah.
Yeah, pretty much, yes.
Yeah. So what we talked a little bit about yesterday was that one of the groups felt that I think it was the number B, the B patient, would need probably a more extensive treatment. You know, I can't remember which one it was. I think it was the B one, and that and we had a little talk about that. Probably most people going into withdrawal from food would need, you know, like an inpatient treatment period at least. And something like Acorn is actually a really excellent model for detoxing. It's like a 6-day, 5 nights detoxification, working through becoming abstinent, getting abstinent for relapses, working on your issues, getting all kinds of information. And I don't know if you uh, I don't think you ever did any of Phil's work, have you? Did you do an intensive with him? Yeah, no.
No, I only read the book, and yeah.
Yeah, right.
I haven't done any work with him, no.
Okay. Well, he was just sending me information on his next lecture. He's going to be there next weekend, and I love it. You're going to love it. He's incredible when he starts. So here with the activity, what signs would you expect to see in assessing a problem emotional eater, a food sugar abuser or harmful use, and a food dependent person? So were you able to answer those questions, do you think, to your satisfaction?
No, we didn't go into that, and I haven't done that either. So we can look at that this week. We said maybe we'll meet twice this week.
Yeah.
Because Leor wasn't available on Friday. It was what's her name, the Spanish girl, and Dima and I.
Okay, good. So just to go over that, it is actually, this is very simple. The problem emotional eater is the person that uses food, anytime they feel any kind of feelings. And usually this is on a unconscious level. It usually has started so early for the person and so unconsciously. And the person does this on a very unconscious level. So it is a question of getting that person more aware of what they're doing with their food, learning to do different things with their emotions, rather than eat, to do deal with their emotions in a different way, in a more healthy way, like feeling them, which may be very difficult for a lot of people, but to learn to feel the feelings.
That's why they use the food and the drugs. So yeah,
I know. And for those people, some of them develop into being chemically dependent, others don't. And and a lot of people actually don't, aren't really chemically dependent. And those are the people that don't believe that there is any more. They feel that once they recover from this and become mindful eaters, that everybody else should be able to do that too. And that's not the case, of course. A lot of people that work in the eating disorder field are these kind of people. They have themselves had different eating problems. They've worked on their stuff, gotten into yoga and working with their psychologists and psychiatrists on their trauma, and they're fine. So that others should be able to do it that way. And that is not the case, of course.
Yeah, but that is what is so difficult for people. It's the same with, I have that with my daughter, who is not addicted to substances, but I mean, both her brothers, one is not here anymore and the other one's still here. But she can't understand, why can't they just stop? Because I can.
Yes, right. That's the thing. It's very, 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 and it's that point, that we need to find a way to describe in very, very simple terms. Why can't a person stop? And it is, of course, it's simple, but it is very complicated, and that's why it's so hard for us, I think. So, and then there is the harmful use. It's the person that just hasn't learned proper ways of eating and caring for themselves. As they start doing that, they get the handle of it and are okay. But all of those people really need to stop eating the stuff. or need to learn to do it in real moderation. And of course, the chemically dependent person needs to exclude all the foods that may trigger them and the eating patterns.
You can't ask them to not eat so much. It's just like drinkers or druggers. You can't ask them to use a bit less or to not drink so much. It's not possible.
And this is basically what I wanted you to be very clear about, those three different things. This is the information package that, and I think for the most part through the months now, you're going to be setting up some kind of an information package about science, about what it is all about, this disease, so that you can find very simple terms ways of orienting and educating the client and others. Evaluating data is, this, what I wanted to say about this one is that this is something that as you go along, it just becomes very clear to you, and you learn by just doing. You start seeing and understanding, as you work with people, the degree of the disease, but then the information of the dimensions, of the background information that will help you in understanding that more. Okay, so I think in the dimensions here, we're talking and going through the is the person going to have real withdrawal risk? And if, in my opinion, if a person is coming from relatively healthy lifestyles, and I get a lot of people in to my office that for the most part are doing good things, they have tried to change their ways and have done so. They eat healthy. They've learned that eating healthy is good. They do exercise and they do mindfulness training. They've gone to the psychiatrist. They've done all the things that they're told to do, and they are still just tired of being tired, and they can't control some parts of their life. And one is that sometimes they just can't stop eating. And maybe every night or every day or over the weekend, or no matter how it is and how the symptoms come up in a person, it's the loss of control in their body, which is really killing their spirit more and more. And so what I feel with people that have relatively good lifestyles, the intoxication and the withdrawal risk is not so, it's less than with people that are like real sugar addicts, that eat candy or fast food. Well, and then there's the fast food people, it's the candy people, chocolates, and then there is the fast food people. So there's two categories there. And for those two groups, these people will really have difficult withdrawal risks, and because they're coming from a lifestyle that it is it's a huge change for their bodies. I remember one person that I don't know if I told you about her. She lost her son. I can't remember if he. I think I can't remember how he died, but he was young, like your son, and she couldn't eat. The only thing that she could eat or have was coffee and chocolate, and then she smoked. And when she came to me, she had done that for 2 or 3 years. She hardly never ever ate anything else. And her health was, of course, suffering tremendously, you can just imagine, and her moods and everything. And she just wasn't coming out of it. And I didn't think that I would be able to help this person. I felt that she was that far gone. And of course, her mental state was still so, she was so in her grief. It was just really hard. But she did, and she started eating. It was obviously the right time for her to just really come out of it, and the support that she got. She was there with me for a few months, and she started eating, and she stopped her behaviors. She didn't stop smoking, I think, but she got out of the and she had severe withdrawal symptoms and a lot of aches and pains in her body as she was developing. Her body was adjusting to food again, and as you can imagine. And I would have, if I had had somebody like you there, I would have suggested that she have that, kind of help. And I did, of course, suggest to her to do all kind, the thing to clean out her intestines and really, build that up and do vitamins and minerals and all of that, just really, I do that. I really
Yeah, I
do.
mean, it just helps. It just makes it easier. That's the
Yeah,
thing.
yeah, it helps a lot. So we have different kind of people there. So we need to be aware. And I've had people that have had such withdrawal symptoms and that they were just really clawing their ways through the first days and just looking for candy all over, and it is going crazy, itchy, and
Yeah.
the body
I
crawling.
mean, yeah. And that's where you can see that it is exactly the same as giving up alcohol or drugs, because that's what they have. So you can see now that food can do the same.
Mm-hmm. Absolutely. And for those people, it's been so hard for me to have to send them home over the weekend, not to have them in place, and so that they can have the support that they need as they go through these first days. So for the most part, I would recommend that kind of a situation for most people. But then you will get people in that are not ready to go into anything like that, and you may want to help them take out certain foods. But then you risk having them, because they will be eating other foods that trigger, that they will still be in the grip of the disease and not be able to stop at times, So that's one thing. So that's the biochemical condition and complications. This is what we're basically talking about. Then there is the other. What other things are there that we need to deal with? And this is, of course, where I suggest people really have their health practitioners follow up on, especially when I get people that really have developed a lot of diseases. And as I told you before, I have one person that is really in a bad shape. She's my age, and she's really, out of work and so overweight, and she has a lot of problems. So to have them get help with that that part is very necessary. And to start with it as soon as possible is always my suggestion. But one thing that I see happen is that quite often that once a person gets abstinent, the first few days may be difficult, but then immediately people will start feeling better. And that will kind of, assist the person to keep going. Digestive problems, if they have digestive problems, they usually need, in my experience, to have help and help their digestive systems onward. Like me, for example, I've been abstinent all these years, but I have a very sensitive digestive system, and I need to always care for it and be sure that it is in the right balance. Hypertension and/or thyroid problems that really lower the low not low blood sugar, but blood pressure. Low blood pressure is one of the things that I see a lot in people with food addiction, and for
They
those
don't
people,
drink enough.
say what?
A simple thing is that they don't drink enough water. I was told that myself many, many years ago by a nurse who said, "Did you drive here?" I said, "Yeah." She said, "You shouldn't be driving. Your blood pressure is so low that you can just pass out."
Wow.
So she said, "Drink, drink, drink."
Right.
And I learned that because I come from a cold country, and here you have to drink a lot more.
Right.
And your blood pressure can't stay up if you don't have enough liquid in your body.
Right.
So I learned that a long, long time ago from myself. It helps. It's not always, but it does help.
Yeah. I know I have this problem of drinking enough, and my blood pressure tends to go really low. So I know from my own experience. And also Bitten, I was talking with Bitten about this, and she has a special hydrochloric acid treatment to help people get their blood pressure up also. So that is assisting their digestive system somewhat.
Yeah, both drinking, and I use hydrochloric acid as well. So
yeah,
and it keeps my blood pressure really good.
right. I need to check on this myself. I'm gonna go and check in the pharmacy about it and do a little treatment on myself so I can help people with that also. So and also with the diabetes, there's a lot of people that have diabetes too, of course, and it's my experience that most people with diabetes 2 just the symptoms just disappear in a few months with proper foods and with being abstinent for these foods and eating those, even eating 3 meals a day, if they're having enough food, is going to be enough for these people. I have a lot of people like that, but every once in a while, a few of those will need in between meals. But it is the diabetes 1 types. I have been working with one for the last year now, and we've had quite a bit of difficulty in regulating his insulin intake and the food, but it is the first time he has any control over it at all, of course. And it's actually it's Benedict who is participating here from Iceland. He's the diabetic, and I would love to for maybe you and I was actually going to ask Bitten to maybe help me a little bit with how to. I think we're coming to a pretty good standpoint with it, but we're still working on it. It's taken a long time.
Yeah, to stabilize it. It's type 2 diabetes is quite easy to reverse with good food and lifestyle.
Yes,
Type 1 diabetes is a little bit different.
yes, absolutely, for sure. And needs a lot of attention, and he was pretty far gone also, with it. And this is, since he was abstinent now for a year almost, it's the first time in his life basically that he's had some kind of stability with it. So it's much, much better, but we still have some ways to go with it. Depression, I think almost everybody that comes to me has some degree of depression, anxiety problems, and I think that is absolutely a result of the foods that we're eating.
Oh, absolutely. There's no doubt about that.
Or not eating.
Not eating or eating, that's correct, yes.
Yeah. So checking on all of these things is very, very important, I think. And now we come to the emotional behaviors. Just really, when I get people in, it's very, very often that they start weeping. They weep and cry. Finally, they feel that they're in a place where somebody understands, and they're going to be supported with this, and they go into, they're the victim of this disease, and are being supported with it. And so a lot of people with this disease have crying spells, and that is one of the things that I can see people as one of the withdrawal symptoms, as I've talked about.
Oh, yeah, because it is biochemical as well.
Yeah. Right. Of course, I don't know, as I'm not, very, very, learned in the medical field, so I'm not really understanding all of that, but I would suggest that it was, for sure. It's such a it's so something that comes up all the time. It has to be.
Oh, yeah. I mean, simple. Mood is food.
Yes.
That's how simple it is.
Yeah, and it all combines, it all combines. So do we want to take a little break, or do you want to just go on?
No, we can take a little break because I need to eat something.
Okay, you go do that, and we'll see you in a few minutes.
All right.
Okay, I can see you there. So if you need to eat, continue eating, just go ahead. I'm good. Are you okay with starting, Monica, again? Okay.
Yeah.
Okay.
Start. That's fine.
Okay, good. I resumed. Yeah, I found out how I can just keep the recording button open on my computer. So as I start, I see it, and then I remember to put it on again.
Oh, good.
Yeah, I'm finding ways to do it, So.
Good.
So we're talking about the emotional behavior conditions and complications, and there, of course, we have start talking about the complicated stuff. The physical stuff is the physical stuff, and the emotional stuff is the emotional stuff. And I heard Bitten say yesterday that she would not recommend a deep trauma work with a person that is starting off in recovery for any kind of substance abuse, And I tend to agree with her up to a certain extent. And I do still, use like, and I do think that people do benefit from doing something similar to Pia Melody's work. I do something similar to that with the hypnotherapy work, which is a soft way of learning self-care and self-soothing. And so it's a learning of self-soothing techniques that I think is so important as we start working. And really what I do in my work is to get the memory, the person from a really difficult memory, from a trauma memory, get that person into a safe place, basically.
Because I think what Bitten was saying, from what I heard, was that the deep trauma she doesn't touch until 2 years.
Yeah, and I can see where that is necessary for some part, but I think it is, it is different. The kind of ways that we can do it is different, and for some people it might be too much. And I've had clients that have really had to stop because it was too much. And once they started using, the emotions were so horrendous that they needed to eat again, because that was the only. Yes, they relapse.
They relapse, and it's the same with drug and alcohol.
Yeah,
they relapse if you start bringing up too much.
Right. That is why I think it is they learn to get those inner memory parts, the child part, to start developing the part that takes responsibility, which is the sensitive adult part of you, to kind of start talking about these two parts and learning to stand by yourself and support yourself, and those kind of things are very necessary, I think. And I do work with these things, and as things come up for the person and they are ready to go into things, I do work with them and send them to people that can. So there's a lot that comes up emotionally for a person as they are starting this and in the process for the most part. And I know that I love the way that Phil and Mary open up a space for people to really go into their deep, deep fears. But for some people, it might be too much in the early days of detoxification. So, it's always something that it may be a little controversial.
And it's different for everybody.
Yeah, for sure. So, and then we come to the dimension 4, treatment acceptance and resistance. Where's the person, at? Do you feel you have an eating problem? And I can tell you, if somebody was asking, is that irrelevant? Isn't the person knowing that at this point? And no, they're not.
No, they're in denial. We know.
Everybody is in denial, and to some extent. They know that they're having a problem. That's why they're there. But they are still holding on to the idea that once they get it, they will get it. And that's what happens into treatment. Just a few days into treatment and into recovery, people will get the sense of strength again. And then the thought comes up, oh, okay, now I've got it. Now I can do it myself. And that will happen again and again and again until the person has relapsed so often that, they finally get it, because the headache is so bad from knocking their head up against that same wall, and they finally get it. And that's where the relapse is. And this is where we need people sometimes to have relapse. It's the only way that a person will understand the extent of the disease.
I mean, it's part of the whole journey.
Yes, it is. So, and that is what I try to tell people. And I have one person, well, probably two people at this point. One person is specifically, she's been doing this for almost 5 years. She's been in a 12-step recovery group for 3 years. Then she started coming to my recovery groups, and she got 1 month a month ago, and now she's barely doing 1 day. And then she will have a week, and then on the weekend she will relapse. And she's a relapser. And I don't know what's gonna, trigger a recovery for this woman, but she is still hanging on there, which is the miracle within it. She knows that she doesn't have anywhere else to go, and she needs to keep working on herself. And she is actually developed into having marital, her marriage was not going really well. And so they had some marital recovery work, and I'm suggesting to her to have trauma therapy, because she has a lot of trauma in her past, and so we'll see what happens with her. But I sometimes, with these people, I don't know what to do. I sincerely don't. Okay, so yeah, you just you do the best you can. And I think this lady actually has might have some. She was given some medication for epilepsy at one point that really did something to her brain chemistry. So that might be part of the problem, that she can't pass something because of her brain circuits. I don't know. Possible.
Yeah, that's possible.
Yeah, she may be damaged to a point that she can't do it. And so then she will obviously need to learn to deal with this being the best she can do. It's possible. I don't know.
No.
So what kind of recovery environment do we need? Sometimes we really need to get people out of their environment. And I actually talked somewhat yesterday about the environment that we live in, for the most part. Not for the most part, everybody lives in, is that everybody feels that they should be able to eat anything at any time, any point of day or night, and not have any consequences for it. And if you don't do that, you're thought of as you're not good enough, there's something wrong with you, and so this is the society we live in. And it's the same as if it was heroin that we were injecting, that you would go to any gas station, any post office, wherever you'd go, there would be dangling heroin syringes, and you'd be asked, why aren't you going to have one? Why? And this is the environment that we live in. And so it is so essential. And that's what I try to teach my clients, how essential it is to get your tribe, to become part of a tribe that has changed their lifestyle in this way. And that.
Oh yeah, absolutely. Absolutely, because you can't have alcoholics going into a pub, and you can't have people like that hanging around with other people who are doing the same thing. It just doesn't work that way.
It doesn't. And And that's where it comes, is where the codependency comes in. The codependency issues come in for a person to learn to stand by their food. And I think that is probably, having to stand by your abstinence and your food is probably the best, what's the word for it? Assertiveness training that you can have.
Yes, being
For
assertive.
sure.
And codependent people are not very assertive.
And I remember I had this one lady in one of my groups. She was so incredibly wonderful. She had worked for years and years at a hospital, and a female-oriented workplace, and she was in charge of her, her group. So she was like a middle person, and when she changed her eating habits, there were a few people that were always just asking, what are you having? And at one point she told us, she said, okay, now you will stop. You stop talking about this. And then she didn't have to say anything more. But she really put the boundaries out there. And
yeah, if you have good boundaries, that's a good thing.
Yes, and it depends on how you feel about it. If you're shamed about it, the people around you will sense the shame. If you're just like, let go, leave me alone, you will get that respect for sure. So you need to set up your environment. And I, for one, I moved into the country where I live alone in my house with my cat and my dog, and they don't say anything, they just love me. Okay, so I think we kind of finished with this chapter, aren't we? Develop a format for patient assessment. And I wanted to see if you do some kind of an assessment and use the material in this chapter. That's what I want you guys to do. So here you have, like a format that you can really use, which is very, very nice. And this is kind of where I've set up my questionnaire, assessment questionnaire from. Here's the DSM-4 criteria. Here is for the counselor's use only. Okay, anything else we want to talk about with this one? I'm thinking if any questions about the assessment chapter? Monica?
No, not really.
Okay, then I'm just.
I'd like to use it and do it so that I can practice. That's the main thing. Yeah.
Right. I think that is the next thing to do. And I want to go into the screening and assessment tools here, and just to open up the ACORN assessment instrument file.
Yeah.
And see, just for a second, let's see that one. Here you go. So here are a few from ACORN, which I really like. You may be a normal eater if, and I think that this one is a very good one. If a person is in denial, it approaches them for, if there's nothing wrong. This is how it is when there's nothing really wrong. So you have maintained a healthy weight most of your life. Is that a pattern for you? Yes or no?
Yeah.
You can stop eating when you want to. Is that a fact for you? And some people will say, yes, I can always stop eating. But then I ask, okay, so why? But does the food call you and you continue eating within a short while or within a certain, so that's what I need to ask them. So why are you so fat then? I sometimes ask them, so why are you so overweight? If you can always stop eating when you want, why are you
Good question.
Yeah. So I try not to do it in a way that they feel threatened, though. It's a little too direct for some people. So you do not frequently use food to numb your feelings. You are not often preoccupied with food, eating, or weight. So this is the reverse, and I like it a lot because it kind of gets people to understand. Oh, okay, I am quite often preoccupied. They really need to listen to themselves. So this one I really do like. Then there is the eating disorder inventory, which I really like also from them. So that is self-assessment number 2, to check out if a person has an eating disorder, is acting out in eating behaviors, and to find out which ones. And then there is this one here, which I really like also, which is the stages. And it kind of synchronizes with the stages and the dimensions. Oh no, the stages of recovery that we may need to work are in the material. So it's the early stage, middle stage, late stage, and final stage, and then death. And I remember when I got Phil and Mary to come here to Iceland the first time, we did a weekend seminar, and they did these questions. And we had set up the hall that we were doing the seminar in, and they had set up like early stage on one side of the wall and all of these stages. And then at the end of the hall, a big sign that said death. And then we were supposed to just one step forward as we answered a yes to a question, and they asked the questions. And literally, when I finished answering the questions on how I had been before I had started my recovery work, I literally had my nose on the wall where it said death. I think I answered yes to all of the questions in this questionnaire. That's how severe my disease had become. So, and I'm living well today. I laugh all the time. So I like this one because it kind of helps people understand the different stages they may be in. What the danger is in them, if they think, oh, I'm well, if they're in the early stage, let me say that if they're in the early stage, they may develop into full-blown food addicts, or they may not. They're still at a stage where if they got into proper lifestyles, they may delay the symptoms, or get away with, really get away with it if they decided at an early stage that they were going to stop eating sugars and starches and those foods, and would moderate with those foods and start living a healthy lifestyle. They might get away with it. Let's say that. And when they're in the middle stage, they're not so lucky. They are already in the disease. And it's like with being pregnant. You can't be just a little pregnant. You're just either pregnant or you're not. And that's the same with addiction. You're either an addict or not. And if you are an addict, you may be an addict that hides behind the curtains and still lives in your mansion, but then you might be the bum on the street, and you still have the same disease. And that's something to understand. The severity of the disease can be different for different people, and the consequences of it can be different for different people, depending. And so that we need to understand, and that it is a chronic disease that really develops and gets worse through the years. So this is assessment tools that you can use if you find them interesting for you. So you'll take a look at that. Any questions about this one?
No, I think it's a good one.
Yeah, I think so too. So let me see here. I'm going to use share. Screening and assessment tools. Here. And chapter 5. Let's go into, do you see it now, treatment planning? Monica?
No, it's just gray.
Okay, let me see. Why doesn't it come in here? Oh,
I saw the other one, but this one's not coming.
Yeah, I have to put new share. Okay, here you go.
Go away from my food, stupid dog.
I have my dog here on my lap. Let me see.
Yeah, he's a big dog. He's sniffing for my food.
Can you see it now?
Yes.
Okay, good. Okay, so treatment planning. Let's start diving into that. Basically, I think for the most part, you will be learning different treatment planning for the remainder of the time until the spring, and probably for the rest of your life. It's not something that, you will stop. You don't need, learned everything about, and you never have to learn any more about. I think we're going to be absolutely, having new information coming in on a continual basis that will support the kind of treatment and develop the treatment that we're already doing, and hopefully bettering it. And that's, that's what I kind of
like that with everything. When I started nutrition, which is like 40 years ago, it's changed. It changes all the time. You have to keep up with everything. That's just the way it is, and it gets better and better.
Yeah.
Information,
absolutely.
because we have, access to good information.
For sure. Okay, so introduction, process by which the counselor and the patient identify the rank problems needing resolution. Establish agreed upon immediate and long-term goals, and decide on treatment methods and resources to be used. So, and here's the global criteria, which is explain the assessment results, identify and rank problems, formulate agreed upon immediate and long-term goals, identify the treatment methods and resources, and so forth. And then the activity from that. So these are the basis for, basically the basis for treatment planning, to understand what it is that we want to do. And I think, when you are working with an addict, like a drug abuse, some specific substance abuse, like alcohol, drugs, of any kind, or even tobacco, you're just excluding this one substance. With food, it is a little more complicated, as we have talked about. And I for one, uh, I think it is essential to know the basics behind why we would need to do things like taking certain foods out, to even weigh and measure the food, or learning, some kind of measurement for your food intake, and why it is not, for the most part, for most people, enough just to take out certain foods that may be the ones that trigger the brain chemistry, but they need to also learn and have what's it called? A certain perimeters. I can't remember the English word for it right now. To format the abstinence program. Why is it necessary for a person to send in their food, to have a more structured eating plan? Why can't they just? Why is it not enough for a lot of people? And I want to say, for most people that are late stage, final stage, for sure, food addicts need a very structured food plan, both for what they eat and the portion sizes, and that they need the daily support with the food, and to have a support system around it, which is going further than a lot of people with substance abuse do. But I know, for example, Clancy, who is one of the giants of Alcoholics Anonymous, and I know I think I can probably say is Cynthia's sponsor, and I followed up on what he does. He wants his client, not his client, his sponsees, to be in steady contact with him, I think on a daily basis, basically. The same way as people with food addiction are with, for the at least a big portion of the people that seem to have the best long-term recovery do. And that is to send in their food for tomorrow, at least some kind of a plan around it, be supported, have the support in any situation, as if something comes up with the food, that they can always address it with somebody. They don't decide, oh, then I'll just start tomorrow. It's not an option. It's a no matter what program. And we need to put the parameters, I think it's the word, around, format the abstinence very strictly, because, and it's as if we were weighing our food. It's not like 5 grams up or down. It needs to be precise. We need to have boundaries around what we do with the food. And once we have that, we get the freedom. However the person get that boundary, they need to do it, in my opinion, with a support person, which can be an addiction counselor, for example, or a sponsor in a 12-step program. And so they make a boundary with the support that they need and they get, and then they get support to be within that boundary, no matter what. So that is what I suggest that people need. But then, of course, we work on an individualized basis always. We need to step toward the person, the client, and build trust, so that the person is able and capable of telling you, okay, I can't do this, I won't do this, I don't think I need to do this. And then you talk about it, you find out what are you willing to do, and you together decide what it is, and then that becomes the boundary that you got start with. And we will be going more and more into that, but in any treatment for any substance, we need to get the substance out. We need to get the boundaries around the food, the eating behaviors under control. That's always, it needs to be the first thing that we do in treatment. If we can't do that, it at least try to some extent take the sugar out, or the sugar and starch would be my suggestion for the first part, and then go from there. But once you get like somebody in, like for a seminar, like MFM, my treatment, and others maybe are doing, you teach a person to really do the changes with the food. They're going to be supported pretty much for a few weeks to do it on a daily basis, and that makes it possible for them to step into this kind of treatment, this kind of life change, and they all of a sudden understand and realize, once they do it, that they can. And it is then you need to help them understand it is not because they develop the capability, but it is because they are within support system. They become a we support system, and that is what is supporting them. And they need to find ways of continuing in a we support system for themselves. And that's so when we kind of stabilize them there, we can start working on other things, like educating about the science behind the disease, educating about and doing assignments, first step assignments. That's what I do and use, especially in the first weeks, just to understanding what the disease is doing to me and has been doing to me in the past, and what is good about it and what is not. And usually we find out it is not a lot of good around it and about it. And then starting to understand what it is that helps me to continue, because that's what people are wanting to find a way on a permanent basis to do what they need to do in order to be abstinent, to get healthy in this way. And that is stepping into 12-step programs, or working on different things that help them with self-soothing, self-love, and self-care, and start doing things that are going to support them. And this, in this chapter, they're like they talk about with Anna, what they want her to do, and what she is wanting to do is to go to the gym and do different things which are measurable and specific. And here's the SMART goals, which I really like, to try to find with a person these goals, specific, measurable, assignable, realistic, time-related, uh, and define the goals that the person is going to do. And I actually try not to do too much with, just to have the person do something, some change. And it could be just going out for a walk for 5 minutes, but just always doing it. And the more is not always better. And I've learned. But once I do go out for a little bit, it makes all the difference in the world to just go outside, take a look at the ocean and here, and take the dog out and get my head out there, and see nature, and just be in my little town. It just takes my head out of it, and it makes a whole lot of difference for the day. And so that might be a specific thing for me to do, is to take a 10 minute walk every day. It's specific, it's measurable, it's like 5 to 10 minute walk, more if I feel like it, but it doesn't have to be longer. And how is it accomplished? I have like a lot of difficulty with going out and doing exercise. That's one of my weaknesses. I always have to be working on it. So I tend to do it as I go out anyway. And I've already put on my winter clothes. and or when I come back from somewhere, like from work, if I'm going into work, I go out before I go for like a 5-10 minutes, and then I'm just heading into my car and then off. Or when I come back, I go for a little stroll before I go into house, something like that. That is assignable, so that helps me. And also that if I do that kind of a commitment, I decide usually to do it every day. I can't do it just, when I feel like it. It's not going to happen. And I'm in that state right now. The weather has not been that so that I can go out very easily either. But it is something that assists me to do it no matter what. And it has to be realistic. I'm not going to be walking out for an hour here, for sure. It's too much for me. It's too cold outside, even if I really dress well. And my little dog is not going to be able to do that. But mostly me, I wouldn't be. So
Well, we need to swap. Here
What?
it's too hot to go. It's too hot to go for a walk, and well, I go early. I have to go early in the morning because the dog wants to go. So then I go early in the morning instead.
Yeah.
Because then it's too hot.
Yeah, we live in totally different climates, for sure.
Yes, at the moment, yes.
Absolutely. Oh, well, so this is something very simple, that we don't really need to talk too much about, but it is something to have. It's a goal. Find goals with a person. And when people come into treatment, they really come into the 5-week beginners treatment with me. The goal is basically to be there for all the sessions, and it is to send in their food. I try to have them do that. At presently, I have like a 7 people group. And one of the people has never wanted to send in his food, and he will just. I try to kind of address it in some way, not too offensive to him, and he never answers me when I address it. He doesn't answer, and I can't do anymore. He is there. He hears everything that everybody else is doing it. He hears how they are, really finding it good and supportive. And he's just obviously not ready to see that. And he's on a diet, you know, like everybody else, of course, but he's just not ready. At one point, I may ask him, you know, just directly. But, and I have actually done so on an email, and he just didn't answer. So you get different people with different, you know, but for the most part, I support them to do the assignments. I support them to find time, like 5 minutes a day in the evening, to do the assignment of sending in their food plan for tomorrow. And then they have a different kind of a review to see how they felt, what was happening with them physically over the past 24 hours, emotionally, spiritually. Do a gratitude list, do a positive affirmation, you know, and different things like that. And just comment on generally how they were feeling and what they were doing. So that I support them with doing. I support them with reading a daily meditation book, doing a meditation, doing a walk, doing some exercise, and, you know, and the assignments, taking a look at the reading material within the treatment book that they get, the folder, and do the assignments every day a little bit. And so, and then I kind of support them to start doing it for a small, like for a 5-minute break, then maybe expand it to 10 minutes if they want to, if they have the time, but at least always do it every day. They start learning to do things on a daily basis, no matter what. And that's the training I want them to really, really learn. So we're pretty soon on the top of the hour, my goodness. And we're going to be learning more and more about treatment planning as we go along. Next weekend, Phil is going to talk about different treatments, and I'm going to be sending you in the chapter about counseling and different counseling techniques. And it's I'm hoping I will probably take the day off today, but tomorrow morning I will start doing that, and hopefully getting it out tomorrow night or so, then you will have it Tuesday morning, hopefully. I don't think there is so much that I need to change in that chapter at this point. So you'll be getting it in Dropbox. I will put it in Dropbox, and I will also send it to everybody via WeTransfer.
Yeah, now I can actually get the WeTransfer. I didn't get it before, but now it suddenly works. So I don't know these technical things.
Yeah,
you know. But it's working now, so that's really good, because I got bittens like that before. I just went to the Dropbox, but this was good, so it worked.
So now you know that you can, you know, there are both ways, and if you can't access any of it, you just let me know, and I'll send it by email or something, so that you be sure. And I told everybody yesterday that please, if you haven't seen anything from me on a Wednesday, just ask me, send a post or something to ask, or on WhatsApp if there's any new material, just so that you're sure to get, you know, what's out there. And so please do that. And I there might be some material from Phil coming in this week also, this coming week.
Okay.
Right. So I'm going to stop the recording.